we start with the definition of the hypertension. So we discussed that hypertension is not only defined as an increase in the blood pressure, but we say there should be a sustained increase in the blood pressure. I told you that actually hypertension is one of the highly prevalent cardiovascular disease. We discussed the data also. We discussed the data also that this hypertension is most prevalent in age above 50 and above, but we discussed that because of the lifestyle today, it is common in the young population also. We discussed the objectives, what we have to cover, and then we discussed this definition of the hypertension. We discussed the classification, that classification based on the reading of the systolic and the diastolic blood pressure. Excuse me. So we discussed the classification on the basis of the systolic and the diastolic reading. So we classify it as normal, pre-hypertension, stage 1 and the stage 2. So this is the classification. That we discussed some of the causes: sleep apnea, drug-induced chronic kidney disease, or chronic steroid therapy. Then I told you the difference between the primary and the secondary hypertension. Primary we discussed, also called as an essential hypertension. So most of the time, about 90 to 95% of the cases, you will find the patient with the primary hypertension, where we don't know the exact cause of the hypertension. While the remaining 5 to 10% is the secondary hypertension, where there is an exact cause behind that. For example, we discussed use of the drug is responsible for increasing the blood pressure or any renal stenosis. So if you stop that one, or if that thing is corrected, that will be reversed. But the primary hypertension, it's a lifelong. We have to take the medication throughout the life. So then we discussed about the non-drug treatment. If you see the classification, we classify as a pre-hypertensive also. So if somebody is pre-hypertensive, we basically do this non-pharmacological treatment, where we reduce the salt intake, reduce calorie, reduce alcohol, increase physical activity, decrease stress factor, decrease caffeine, and this stop smoking. Then we discuss the lifestyle modification to manage the hypertension. So DASH, that is dietary approaches to stop the hypertension. Then a very important slide, we discuss what are the mechanism of these blood pressure and how these drugs will act. So we discussed there are many reasons. If there is any increase in the sympathetic activity, that increase in the sympathetic activity will activate the beta receptors on the heart as well as on the beta receptor on the kidney. If you remember the slide of the autonomic nervous system, where we discussed a location of and role of these beta receptors. So if you remember, we discussed that beta 1 receptor, they are present on the heart as well as on the kidney. So any increase in the sympathetic activity activates the beta 1 receptor on the heart, that will increase the cardiac output and that increase of blood pressure. Or we discussed that any increase in the sympathetic activity will activate the alpha receptor on the smooth muscle and beta receptor on the kidney, which is responsible for the release of the renin. We discussed the role of the renin also last time, that renin is a hormone which is released from the kidney, and in kidney specifically it is released from the juxtaglomerular cells, which play an important role in the regulation of the blood pressure. So we discussed about that increased renin release is responsible for the formation of the angiotensin 2. Now this angiotensin basically it is synthesized from liver, and the name of the enzyme which is synthesized from the liver is angiotensinogen. That angiotensinogen is converted into 1, and then 1 is converted into 2. So we discussed that what is the difference between 1 to 2? That 2 is vasoconstrictor in nature. So we want to block the conversion of, or we want to block this conversion of angiotensin 1 to 2. So because this angiotensin 2 will lead to the increase in the aldosterone, and we also discussed the role of the aldosterone in the diuretic. So aldosterone is a hormone which plays an important role of the salt and the water balance in the body. So increased aldosterone responsible for increased sodium and water retention, and thus we have an increased blood volume and increase in the blood pressure. So this is actually how we say this diagram is called as response mediated by renin angiotensin aldosterone system, or response mediated by the sympathetic nervous system. I already explained you this figure in detail last time. Then we discussed that the drugs which lower the blood pressure, they act by three main mechanisms. Number one, they act by altering the sympathetic activity. So you will see that we have the drugs that alter the sympathetic activity, and as a result, the blood pressure will be decreased. Then number second, these drugs, they act by relaxing the vascular smooth muscle. So you can see that any drug, for example, we discussed alpha blocker. When we give the alpha blocker here, that alpha blocker stops the activation of the alpha receptor. Thus, there will be decrease in the peripheral resistance and decrease in the blood pressure. Or we can give the beta blocker also. So any here beta blocker, they stops the activation of the beta receptor on the heart, and also they stop the activation of the beta receptor on the kidney, and thus we have a decrease in the blood pressure. Then we discussed that we have some other drugs also. We have direct renin inhibitors that stop the release of the renin. We have the drug which stop the conversion of angiotensin 1 to 2, and we also have a drug which don't stop the conversion, but they stop the activation of the receptors activation. So we say that these are the drugs. So the third mechanism, here we have that these drugs will act by altering the sodium and the water balance. So these were the three mechanisms. Then we discussed the classification of the antihypertensive drug. So we may have diuretics, beta blocker, ACE inhibitor, angiotensin converting enzyme inhibitors. We have renin inhibitor. This is actually comparatively a new drug if you compare it with the other. New means already it's 15-20 years, but comparatively it's a new drug. Then we have an angiotensin 2 antagonist. That is, as I told you, these are the drugs which stops the activation of the angiotensin 2 receptor. So that angiotensin 2 will not be stimulated. Then we have a calcium channel blocker. Inshallah, we'll discuss this today. Then we have an alpha blocker, and then we have the other category of the drug. Other, that means these other category, they follow different mechanism, and they are rarely used actually nowadays. Okay. Then we start with the diuretic. We discussed that all oral diuretics are effective in the treatment of the hypertension, but thiazide was the drug of the choice. If you remember, I explained you what is the reason why thiazide was the drug of the choice. Okay. Then we discussed that the loop diuretics are recommended for the hypertensive patient with the renal insufficiency. I already explained you that with loop diuretic, there is an increased production of the urine, and also the sodium excretion is too much. If you remember the figure, what we discussed in diuretic, so that's why we prefer loop diuretic in hypertensive patient with the renal insufficiency. We don't prefer loop diuretic in the normal hypertensive patient because there is a risk of the hypotension. Because we discussed last time that loop diuretic, they are the most efficacious diuretic which is responsible for the excretion of the sodium, and also there is too much volume of the urine. So what are the therapeutic uses and what are the adverse effects? We already discussed earlier. Then the second one, where we have beta adrenergic receptor antagonist. We discussed also last time that how these drugs will act. These drugs basically affect on the central nervous the peripheral nervous system. So they decrease the sympathetic nervous system tone. Also, as I told you, that these drugs, these beta receptor blocker, they stop the activation of the beta receptor on the heart. As a result, we may have decreased cardiac output and decrease in the blood pressure. And these beta receptor blocker, they also inhibit the renin release. So we discussed in the previous diagram that decreased renin leads to decreased angiotensin 2, decreased aldosterone, decreased salt and water retention, and thus there is a decrease in the blood volume and decrease in the blood pressure. Okay. Then we discussed that these beta blockers, they are more effective for treating the hypertension in white patient compared to the black, and in young patient compared to the elderly. We don't know the exact data, that what is the reason, but the studies show that it is more effective in young patients as compared to the elderly. Then we discuss about the therapeutic uses. We also discuss the side effects of the beta blocker, that we may have bronchospasm. If you remember, we discussed that apart from the heart and the kidney, one of the important location of the beta 2 receptor is in the lung or in the bronchioles. So when you give the beta blocker, that beta 2, we discussed that what is the role of beta 2. Beta 2 stimulates the bronchodilation. That's why in asthma we give beta adrenergic receptor agonist to stimulate the bronchodilation. So when you give the beta blocker, it may cause bronchospasm. Hypertension, we know why hypertension, because we are giving the drug to reduce the blood pressure. So there are chances that the one may go into the hypertension. And I also told you very important point, that whenever you start any hypertensive therapy, in the new patient, so for the first few doses we have to be careful, because sometimes there is a risk of the hypertension. Then once the patient is tolerated, you can see everything is okay, then you can prescribe for the longer period of time. That's why we always start with the lower dose, we don't give with the higher dose, and if the blood pressure is controlled, then well and good. If not, then we can increase the dose. So we may have bronchospasm, hypertension, fatigue, bradycardia. Again I told you bradycardia, because if you see the role of the beta 1 on the heart, responsible for the tachycardia. So when you give the beta blocker, there are chances that one may have a bradycardia. Decreased libido, we discussed that this is actually a very rare adverse effect in those patients who are taking the beta blocker for a longer period of time. Okay? Then we discuss about the drug withdrawal. So the dose of the beta blocker must be taken over 2 to 3 weeks in patients with the ischemic heart disease. Then we discuss about the alpha blocker. I told you that this alpha blocker, basically they classify it as a selective alpha 1 blocker and also the selective alpha 2 blocker. So we have selective blocker alpha 1, that is prazosin, terazosin and doxazosin. So we give these drugs for hypertension, and we also give this drug for benign prostate hypertrophy. One of the adverse effects we discussed with the alpha blocker is the orthostatic hypotension, which occur within 30 to 90 minutes after giving the drug. So orthostatic, I told you that any change in the blood pressure with respect to the position. Okay. So if you are lying down, maybe your blood pressure is okay, but if you just stand up, maybe your blood pressure will be low. Okay. So this is about the alpha blocker. I think we stop it here, right? Yes. Isn't it? So whatever we discussed was just the revision of the previous class. So the next class of the drug which is used for the treatment of reducing the blood pressure, we have a calcium channel blocker. Now this calcium channel blocker, they are classified into 2 types depending upon their structure. So we say non-dihydropyridine, and then we have a dihydropyridine. Dihydropyridine basically, maybe if you know in chemistry, that is a ring-like structure. Okay? So some drugs, calcium channel blocker, we say dihydropyridine, which have that dihydropyridine ring, and the other we say non-dihydropyridine. Okay? So we have the drug in non-dihydropyridine, like we have a verapamil and diltiazem. These are the drugs in the non-dihydropyridine, and the other calcium channel blocker which ends with the pene. So we discussed amlodipine, nisoldipine, nicardipine, nifedipine. I told you this is one of the ways how you can memorize the drug also. So we discussed in beta blocker, the drugs end with the lol. There are some exceptions. I repeat, there are some exceptions, but most of the time you will see the beta blocker, the drugs end with the lol. The alpha blocker, the drugs end with the sine. The calcium channel blocker, the dihydropyridine, the drugs end with the pene. And the other, we have an exception like non-dihydropyridine, we have verapamil and the diltiazem. So you have to memorize only few, and the rest automatically with their name you will recognize. So we have non-dihydropyridine, verapamil and diltiazem. How these verapamil will act? We know very well that calcium is very important for the function of the heart. So these verapamil, they basically block the L type of the calcium channels of the heart. So we have a calcium channels of the heart, L type, and then we have on the muscular smooth muscle also. So this non-dihydropyridine, they block the L type of calcium channel on the heart, and they have negative inotropic and chronotropic action on the heart. What I mean to say inotropic that related with the contractility. So if I am saying positive inotropic, that means increase the contractility of the heart. What I mean to say contractility, you know that when the heart muscles contract, then they start pumping the blood. Okay? So these are the drugs, they basically reduce the contraction, the heart contractility. So that's where we use the word negative inotropic. Okay? And then they also have a negative chronotropic action on the heart. What I mean to say chronotropic, that they decrease the heart rate. Okay? So inotropic contractility and chronotropic we say decrease the heart rate. So this verapamil have negative inotropic and chronotropic action on the heart. And then we have another diltiazem. If you compare verapamil with the diltiazem, this diltiazem basically is intermediate in action. Okay? Then we have other category of the drug, which is a very good category, that is a dihydropyridine. What is the difference? That this dihydropyridine now blocks the L type of the calcium channels on the vascular smooth muscle, and the drugs we discussed, that nifedipine, amlodipine, nisoldipine. This amlodipine is very frequently prescribed for the patient with the hypertension. Those who are newly diagnosed, most of the time will prefer this amlodipine. So how these drugs will work? These drugs will dilate the arterioles, decrease the TPR, which stands for total peripheral resistance, and thus they decrease the blood pressure. Okay? So these are the calcium channel blockers. So we say that these decreased TPR is less with the verapamil and more with the nifedipine or the amlodipine. Yes.
Okay. And the dilatism in the middle of the slide, that it said intermediate in its action. I didn't understand this point.
Intermediate, we discussed that some drugs they are long acting, some drugs they are short acting, and some drugs they are intermediate in acting. Okay, so we said this is an intermediate in action.
He means the duration of
the duration of action, yeah.
Okay.
And there was one more question. You were asking something before also. Let's see after the class. Then what is the adverse effect of calcium channel blocker? Number one, we have cardiac depression, and then we have a bradycardia, and then we have an atrioventricular block, and then we have an adverse effect of the dihydropyridine, constipation, flushing, dizziness, and headache. Hypotension, we discussed that. Now if you see the adverse effect also, this dihydropyridine, which we discussed, as I told you, more frequently prescribed, they have a lesser adverse effect than the non-dihydropyridine. Okay? So this is about the calcium channel blocker. Then the next class of the drug, we have a... Yes, please.
What is AV block?
What is AV? One of the chamber of the heart. If you see, we have 4 chambers. So one of the chamber of the heart is atrioventricular.
It stops pumping.
Stops. You got my point? Okay. So it's one of the chamber of the heart. Then we have a vasodilators category. So these drugs, they cause the relaxation of the vascular smooth muscles, which decrease the resistance and therefore decrease the blood pressure. These vasodilators, we don't prefer actually these vasodilators, because we have some very other good category of the drug. We discussed beta blocker, we discussed the calcium channel blocker. Now we have angiotensin converting enzyme inhibitor, which we'll discuss after that one. Also we have angiotensin receptor blocker, very good drug. Because of their adverse effect, we don't use vasodilator very commonly, but yes, in some patients we need to give this one. For example, we have hydrolazine. Hydrolazine, basically it has been used in hypertensive pregnant women, less used nowadays because this can cause a condition which is called as a lupus erythematosus. Lupus erythematosus, it's an autoimmune disease, maybe you know about that one. In short form, we say SLE, systemic lupus erythematosus, in which our immune system of the body by mistake attacks the healthy tissue. So you will see those who have this systemic lupus erythematosus, there are multiple organs involved. Okay, their kidneys are involved, and then other heart function is also declined. So it's actually, And the treatment also, it's, the outcome of the treatment is not that good with the patient with the SLE. Those who have an SLE, most of the patients, they don't survive for a longer period of time. Okay? Yes, please.
Is it that one disease that appears like a butterfly redness on the face?
Yeah, this actually, as I told you, that this is the systemic. So you will see multiple organs. You will see those patients, their hemoglobin drops frequently. Okay, because we know that because of the immune system attack the healthy tissue. So these red blood cells that is not formed. So you will see hemoglobin frequently drop. They have to visit multiple times in the hospital. Okay. So we have hydrolysine, and then we have a minoxidil. Now this minoxidil is used previously for the treatment of severe to malignant hypertension. Okay, very interesting story this one. The minoxidil was a very good drug previously, long time before, but when the patient, they were using the minoxidil, the blood pressure is controlled, but they have having this arrhythmias problem, okay, irregular heartbeat. So because of that, they withdraw the drug minoxidil for the purpose of hypertension. And when they were using the minoxidil orally, there was one adverse effect that is called as hypertrichosis. Hypertrichosis, it will come in my later slide, that is increase in the growth of the hair. Okay? So when they withdraw, and nowadays you will see minoxidil is available in the pharmacies as a topical application, 2% or I think 1% topical application, which the patient they use for the baldness, those who wants to grow their hair. Since we are not using systemically, we are only using topically, so you don't have this adverse effects of the arrhythmias. Okay? But as far as for the hypertension is concerned, minoxidil is no longer used for the treatment of the hypertension. You got my point? Yes, please.
So, alpha-adrenergic blockers, they block the alpha channels. Calcium channel blockers, they block the calcium channels.
Alpha, they block the alpha receptor.
Alpha receptors, yes. How do vasodilators vasodilate?
They basically, we will discuss now also, because if there is any constriction, they are responsible to remove that blockage. Okay? So they basically reduce the vasoconstriction. So thus, when the vessels become dilated, you may have reduced the blood pressure. Because we discussed that in the beginning last time also, there are many reasons of the hypertension. One of the reasons is if there is a vasoconstriction also. That vasoconstriction lead to the blood pressure. We also discussed activation of the adrenergic receptors. We also discussed that increased sodium in water retention also responsible for increase in the blood
Do
pressure.
they participate in any receptors like the beta receptors or alpha receptors or no?
Vasodilators not directly, but beta adrenergic receptors, they basically they are one of the main function also, because when they stop the activation of the receptor, the vessels also become dilated. Okay, so
they
indirectly
participate-
but they are not activating any receptors for
Okay.
beta. You got the point? Okay. So this is the minoxidil. Then we have a dioxazide. If you remember, I think we discussed in autonomic nervous system also, dioxazide and the sodium nitroprusside. These are the two drugs which we use for the hypertensive emergencies. Okay. What I mean to say emergencies, that if it is exceed stage 2 hypertension, we discussed that any increase in the blood pressure 160 and above, we consider as a stage 2 hypertension. Okay. So diazoxide is available only for the intravenous use in the treatment of the hypertensive emergencies. Also we have sodium nitroprusside also available as an intravenous in the hypertensive emergency. What are their adverse effects? We have a reflux tachycardia. I just explained you about that those who are using these minoxidil, they may have this arrhythmic problem. So we have reflux tachycardia, then we have a possible fluid retention. So still those who are using the vasodilator, we basically prefer to combine it with the diuretics, because we know that there is fluid retention, so that may worsen the hypertension. Also hypertrichosis, we discussed that it is an excessive hair growth which is specific with the minoxidil, hyperglycemia which is specific with the dioxazide. So vasodilator may lead to decreased sodium excretion and increased renin release that can worsen the hypertension. So they should be co-administered with the beta blocker to decrease the heart rate and the contractility, and also with the diuretics to treat the edema, because that diuretic will increase the sodium excretion, and also the fluid retention will not be there. So this is about the vasodilator. The next drug, which we say is called as angiotensin converting enzyme inhibitor, which is abbreviated as the ACE inhibitor. Again, you see, all the drugs with the ACE inhibitor, they ends with the pril, captopril, enalapril, lisinopril, and the fosinopril. It is the first line of the treatment of hypertension in patients with the variety of compelling indication, including the high coronary disease risk, diabetes, stroke, heart failure, myocardial infarction, and the chronic kidney disease. Now, why we prefer this in like diabetes or chronic kidney disease? Apart from their antihypertensive effect, lisinopril or these ACE inhibitor, they are also responsible for reducing the proteinuria, because in diabetic patients and those who have a chronic kidney disease, you will see that this patient, because of their poor renal function, and even with the diabetes, with the passage of time, the kidney functions decline. So you will see the proteins leak in the urine. And if there is a continuous proteinuria, that continuous proteinuria further damages the kidney. Okay? So we prefer this kind of the drug, because this drug will not only control the hypertension, but will also control the proteinuria in patients with the, especially in patients with the diabetes or the chronic kidney disease. Okay? Now, how these drugs will work? These ACE inhibitor, they lower the aldosterone, they lower the elevated blood pressure by different mechanism. Number one, if you remember, we discussed that these drugs, they stop the conversion of angiotensin 1 to 2. We discussed that 2 is the vasoconstrictor, but 1 is not the vasoconstrictor. So if you go back to the diagram, we discussed if it is stop the formation of angiotensin 2, then also decrease the aldosterone secretion. So we say one of the main mechanisms in ACE inhibitor, that they decrease the aldosterone production and they decrease the sodium and the water retention. Then number second, we discussed that these drugs will decrease the angiotensin 2, thus they decrease the vasoconstriction. Number third mechanism, that these drugs, they are responsible for the production of the bradykinin. Okay? Now this bradykinin is basically a vasodilator in nature. So increased bradykinin will lead to the vasodilation, and thus they decrease the blood pressure. But you will see that those patients, let's say about 25 to 35% of the patients, those who are taking the ACE inhibitor, the one important adverse effect they have, that is the dry cough. Dry cough is one of the important adverse effect of the ACE inhibitor. And why they have a dry cough? Because of the production of the bradykinin. So bradykinin, on the one hand, they are vasodilator, decreasing the blood pressure, but on the other hand, in some patients, not all, they have this dry cough as an adverse effect. This is very important diagram. As I told you, this angiotensinogen, everybody on the screen please. This angiotensinogen is basically released from the liver, and from the liver, this angiotensinogen, when it comes in the blood, they are responsible for increasing the renin from the kidney. Now we discussed the role of the renin. This renin now responsible for converting the angiotensin 1 to angiotensin 2. If you remember the diagram, we discussed that increased renin leads to increase in the angiotensin 2. So this renin convert 1 to 2. So what will happen when we give these ACE inhibitor? This ACE inhibitor stop this conversion. So there is a decrease in aldosterone, there is a decrease in the outflow of the sympathetic, increased vasodilation because of the bradykinin, and we discuss also increase in the retention of the sodium and water, and thus there is a decrease in the blood pressure. Okay? So this is actually the mechanism of ACE inhibitor. Nowadays, some studies shows that if you see the next category of the drug, we have angiotensin receptor blockers. They are more effective than the ACE inhibitor because they are not stopping the conversion, they are stopping the activation of the angiotensin 2 receptors. Got my point? Okay? But as I told you that this drug have a dual function. They also control the proteinuria. Angiotensin 2 receptor blocker also control the proteinuria, but these ARB stand for angiotensin receptor blocker. Some consultants they more prefer over ACE inhibitor. Okay, so this is about the mechanism of action. What are the pharmacokinetics? All ACE inhibitors except captopril and lisinopril are the prodrug. Prodrug, that means that they undergo activation with the help of the liver. Okay, so after the metabolism, they convert into active metabolite, and that active metabolite is responsible for producing the action. Some drugs we say they are the prodrugs. Okay, so all ACE inhibitors except captopril and lisinopril, they are the prodrug that undergo hepatic conversion to active metabolite. So we prefer these agents, captopril and lisinopril, in those patients with the hepatic impairment. Okay? Because we know that in hepatic impairment, they are not responsible, they cannot convert into active metabolite. So we prefer these drugs which does not go or which does not consider as a prodrug. Fosinopril is the only ACE inhibitor that is not eliminated primarily by the kidney. Therefore, it does not require dose adjustment with the renal impairment. Okay? Then one of the adverse effects also we see here that those patients when they are taking the ACE inhibitor, there is slight increase in the creatinine level of the creatinine. Okay? Because we discussed also last time what is creatinine. It is one of the marker of the kidney function. Whenever some patient they have a problem with the kidney, we always check the level of the creatinine in the blood. And how it is coming in our body? It is coming from the protein. Whatever the protein you are taking, the end product of the protein metabolism is the creatinine. So that's why those patients who have a compromised renal function, we always say that limit your protein intake. Because higher the protein you intake, more creatinine will be formed in the blood. Okay? And creatinine, we discussed, it is one of the toxic products which should be excreted from the body. Okay? So in normal patients, since the kidneys are functioning properly, so that creatinine will be excreted. But in the patient with the renal compromise, since the kidneys are not functioning properly, so that creatinine will be retained in the blood. You got the point? If you remember, I gave you the example of the kidney. It's just like a strainer. If you pour the tea in the strainer, you will see the liquid comes down and the solid retain above. Okay? So same with the kidney, that the proteins are retained above and then the toxic material will go out. But sometimes when the nephrons become sclerosed, nephrons become blocked, so what happens? Those toxic material will not be go out. Or sometimes when if you have a big holes in the strainer, what will happen? The solid will also enter. So that's why sometimes when there is any problem in the kidneys, so that proteins also leak into the urine. Okay? So these are about the fosinopril. Enalapril is the only drug in this class available as an intravenous. Then what are the adverse effects? We have severe hypotension in hypovolemic patients. Then as I told you, about 39% they have a dry cough, angioedema, altered taste. Dry cough is the main adverse effect, and the other, they are only in some patients. Then we have reversible renal impairment in patients with the renal artery stenosis. I just explained you. In some patients, you will see there is slight increase in the creatinine, but that is reversible. So we say reversible impairment in patients with the renal artery stenosis. It is contraindicated in the pregnancy. It is teratogenic. If you see this, basically the drug is categorized as a category D drug. Then the next category of the drug we have is angiotensin receptor blocker. As I told you that this angiotensin receptor blocker, they block the action of the angiotensin 2 more complete than the ACE inhibitor. Once daily dose is enough, losartan, and this all ARBs, the drugs end with the sartan. Previously we discussed the pril. Now how you know that they are ARB blocker? That the drugs end with the sartan. We have many drugs, valsartan, candesartan. So these drugs once daily dose. Losartan undergoes extensive first pass metabolism. These agents are also teratogenic and should not be used by the pregnant woman. Then we have other category of the drug. We say renin inhibitors. We have only one drug in this category, which is called as alaskirin. As I told you, this is actually a comparatively newer drug. Okay? If you compare it with the other drug, they are comparatively newer drug, but it's been now used since long time. Mainly cause diarrhea as a side effect. Alaskirin again is contraindicated during the pregnancy. Then we discussed that some drugs, they are called as a centrally acting drug. Okay? So we have a clonidine, which is a centrally acting drug, which basically, if you remember, we discussed in autonomic nervous system that it is an alpha-2 receptor agonist, clonidine. Okay? And this clonidine, what is the difference between clonidine and alpha-methyl dopa? The principal difference between clonidine and alpha-methyl dopa is that clonidine acts directly to the alpha-2 receptor, whereas methyl dopa, first they release the hormone, the methyl norepinephrine, the neurotransmitter, and then they activate the receptor. This also we discussed in the autonomic nervous system. The therapeutic uses we use for mild to moderate hypertension. Clonidine is suitable for the patient with the renal failure, but the adverse effect we have a sedation, and also a dangerous effect is rebound hypertension, which follow the abrupt withdrawal of the clonidine therapy. Again, very rarely used drug. Those patients who are not effective or their blood pressure is not controlled with the use of the other drug, then we use the clonidine. So you can consider that clonidine as among the last choice of the drug. Yes, please.
Can you explain the first adverse effect?
Which one?
The first one.
Sedation.
Yeah, how does it happen?
Because we discussed it acts on the central nervous system.
Yeah, so when
Okay.
the patient takes the
So
drug,
it may produce sedation, and you will feel sleepy.
you feel sleepy.
Sleepy, yeah. Sedation is sleepy.
Okay, so the patient does not sleep or something. That's the central nervous system.
Then you feel sleepy, right?
Yeah.
Okay, you feel sleepy, so that's why we prefer this drug to given at the bedtime.
Okay.
Okay, because this is a centrally acting drug. We discuss in autonomic nervous system that they activates the alpha-2 receptors. You got my point?
Yeah.
So because of the centrally acting, it produces the sedation.
Okay.
Yes, what else?
What's the function of aldosterone?
Aldosterone, we just discussed that in diuretic also they are responsible for increase in the sodium and the water retention. So as a result, what will happen? That if you have an increase in the sodium and water retention, there is a lots of fluid accumulation and sodium accumulation. So you remember we discussed that which diuretic we discussed belongs to the aldosterone antagonist. Let's see your memory. Which diuretic we discussed belongs to the aldosterone antagonist. So we discussed thiazide and loop you give, but there are some problem with the potassium, so we give the other class of the diuretic. What is that called? Potassium sparing diuretic. So if you go to the diuretic lecture, potassium sparing, we discuss the act by two mechanisms. Number one is aldosterone antagonist. You block the aldosterone, where is the sodium and water retention decrease, and thus you will see there is a decrease in the fluid accumulation. So aldosterone is a hormone which is responsible for increase in the sodium and water retention. Also we discussed in this diagram. Aldosterone, increase aldosterone, and then you have increase in the sodium and water retention. You got the point? Yes. So this is about the clonidine. Then the second one is the alpha-methyl dopa. If you remember previously we discussed that in the pregnant mothers, okay, some drugs they are teratogenic, but alpha-methyl dopa is one of the safest antihypertensive which we can use during the pregnancy also. Alpha-methyl dopa available as an oral, and we have some alternative as an intravenous also. But usually when the mother blood pressure is high during pregnancy, we try to control with the other non-pharmacological approach, any reduced diet, slight or we can say little walk. But if it is not controlled, then we can give this alpha-methyl dopa also, which is one of the safest antihypertensive I think in here in Saudi Arabia it is available by the brand name of Eldomet. Okay, so this one alpha methyl dopa. What is the difference? As I told you, the difference between clonidine and alpha methyl dopa. That this alpha methyl dopa enter into the brain and convert into alpha methyl norepinephrine, which releases and activates the central nervous system alpha 2 adrenoreceptor, whose function is to decrease the sympathetic outflow. So it is used in the treatment of hypertensive patients with the renal insufficiency. Alpha methyl dopa, in addition to the labetalol, hydralazine, and mifedipine, they are the drug of the choice for hypertensive pregnant women. So we can give these drugs, alpha methyl dopa, also labetalol, hydralazine, and mifedipine, which are the drug of the choice for the hypertensive pregnant women. Then we have some other category of the drug. You don't see these drugs nowadays. For example, phenol-dipam, which was a dopamine 1 agonist. It is safe in all hypertensive emergency patients, especially with renal failure. This drug is responsible for increasing in the intraocular pressure, so it is contraindicated in the glaucoma. Again, there is one more rarely used drug, that is a guanethidine and reserpine, used long time before, but nowadays, because as I told you, we have some better agents available, so nowadays we don't use these guanethidine or the reserpine or even with the phenol-dipam. Okay? Then the last slide, we have the drugs for hypertensive emergencies. So what I mean to say, hypertensive emergencies, when systolic is greater than 180 or diastolic is greater than 120, because you know that if the, as I told you in the beginning also, that hypertension is considered as a silent killer. Sometimes you feel, okay, if you have a headache, headache always does not indicate there is an increase in the blood pressure, but headache may be one of the symptoms. But sometimes you will see the patient, they don't feel, they have a high blood pressure since long time, but they don't have any symptoms. How many times we saw in the hospital, the patient came and suddenly they have this renal failure. What was the reason? That they were hypertensive from a longer period of time, and when you ask them, they say, no, our blood pressure is okay. And when you ask them, did you check your blood pressure? They say, no. So that's why we say hypertension is a silent killer. So uncontrolled hypertension can lead to any, problem in the heart, problem in the kidney, problem in the eye, anything. You see, most commonly, those who have a renal failure, most commonly you will find the two reasons. Some patients, they have an autoimmune disease, that is another story. Most commonly you will find the two reasons, diabetes and the hypertension. These are the two reasons which are responsible for the organ failure. Okay? In hypertensive emergencies, as I told you, that if the blood pressure is greater than 120 or 180 and 120, we consider this is an emergency condition, because anything can happen. We know that, I just always give the example of the balloon to the student. When you put the air in the balloon, at some point what will happen? When the pressure is high, it becomes burst. So this high blood pressure can cause internal bleeding. Okay? Damages, or there is any internal bleeding, there is a risk of clot formation also. Okay? So remember, we have one case there when the patient arrived, her blood pressure was 200 and 130, and there was a bleeding from the nose. So if there is a bleeding from the nose, that is good actually, because the pressure is reducing. Okay? So this actually is the case. So if we can give these sodium nitroprusside IV, which is used for emergency and the malignant hypertension. We also use labetalol. If you remember, in autonomic nervous system, we discussed that it acts on both alpha and the beta, and is given as an intravenous bolus or the infusion in the hypertensive emergencies, and we also give the diazoxide as an emergency. What is the difference between bolus and infusion?
Infusion over a certain period of time, bolus just one
At
time.
once, very good, mashallah. Bolus at once, and infusion, you see sometimes the patient, they have a large water bag, and we put the drug, and drop by drop, the drug goes in the blood, that is called as an infusion. While bolus, we say at once, when the drug rapidly enters. We have many drugs you can give as a bolus, and we have many drugs you can give as an infusion. But whenever you give as an infusion, one thing, make sure that we have to select the compatible solvent for that. Okay? Sometimes you will see when we prepare the infusion, we use the normal saline or we use dextrose. These are the things which we use for the preparation of the drug. Okay? So there is a difference between the infusion and the bolus. So student, this is all about the hypertension drug. As I told you again,